Just in case you don't know where morphine and natural occurring opioids come from, they come from opium, from the opium poppy. That's what the flower looks like. And it produces a bud, and the bud contains a sap, which can be harvested, and opium comes from that sap. Okay, let's talk a little bit about genetics. So generally, opioids are metabolized by three processes in the liver: glucuronidation, N-methylation, and O-demethylation. If we take a look at codeine, codeine itself is not an analgesic. It has to undergo O-demethylation via the cytochrome P450 enzyme 2D6. O-demethylation transforms codeine to morphine, and thus the impact of codeine. Turns out that about 9% of a white population is deficient in the 2D6 enzyme, and therefore codeine doesn't do anything because it's not converted to morphine. If we take a look at this enzyme, we find that, again, about 9% on average in a white population has reduced or absent activity of this enzyme, so codeine will not be transformed into morphine. There is a subset that have increased activity of this enzyme, and maybe codeine will be more potent than expected. It is unusual to have reduced 2D6 enzyme, cytochrome P450 enzyme, in Asians. So usually you do not see this problem of codeine not working in Asians. Usually that's not an issue. In an African population, it depends where in Africa. So in certain parts of Africa, you can get up to a third of the population with reduced activity of the 2D6 enzyme, and therefore codeine won't work. And in other parts of Africa, that problem doesn't exist. And in some parts, they have increased activity, so again, codeine may be more effective than expected. There are other cytochrome P450 enzymes. So 2D6 is the key one for codeine. 3A4 is the primary metabolizer for fentanyl and oxycodone, with 2D6 playing a minor role. Tramadol uses both the 3A4 and the 2D6 enzymes. Methadone is 3A4, 2B6, and a whole bunch of others. And because there's a whole bunch of liver enzymes, the risk for drug-drug interactions is highest with methadone. Okay, so part of what we're going to end up talking about is urine testing. So here's a question for it. Which of the following are causes of false positives with urine drug testing? Choice A, and each of these choices has two parts. Both parts have to be true. Choice A, hydrocodone can cause a false positive for hydromorphone. Poppy seeds can cause a false positive for morphine. B, poppy seeds can cause a false positive. Oxycodone can cause a false positive for hydromorphone. Choice C, some NSAIDs can give a false positive for cannabinoids. Oxymorphone can cause a false positive for hydromorphone. Choice D, codeine can cause a false positive for morphine. You might suspect that's true because I just talked about how it is metabolized into morphine. And the second part of it is oxymorphone can cause a false positive for oxycodone. Choice E, sesame seeds can cause a false positive for cannabinoids. Hydrocodone can cause a false positive for hydromorphone. Correct answer. Hydrocodone can give a false positive for hydromorphone. We'll explain why in a bit. And poppy seeds can induce a false positive for morphine. So some of the other things that are not true, oxy-opioids do not metabolize to hydro-opioids. I'm going to go over a couple of metabolism rules in a minute, but one rule is if it starts as an oxy, it stays an oxy. If it starts as a hydro, it stays a hydro. They don't metabolize to each other. Some NSAIDs do give false positives for cannabinoids. That is true. Oxy-opioids do not metabolize to hydro. Again, oxy stay oxy, hydro stay hydro. And sesame seeds don't do anything as far as I know. Okay. Here's a metabolism chart. This looks daunting, but with just two rules. You just got to memorize two rules. And if you memorize the two rules, you got opioid metabolism down. Okay, so I already told you both rules. One rule is that codeine produces morphine. All you have to do is generalize that. Codones metabolize to morphones. They don't go the other way. Morphones never metabolize into codones. Okay? So just remember, codeine turns into morphine in order to become effective, and you got that rule. Codones go to morphones. The opposite is not true. Morphones do not go to codones. And then the other rule I told you is oxy stay oxy. So like oxycodone produces oxymorphone, right? Oxy to oxy, codone to morphone. And hydros stay hydros. Hydrocodone will produce hydromorphone. Hydro to hydro, codone to morphone. Okay? Just remember those two rules and you got it. Okay? Oxy stay oxys, hydro stay hydro. Codone to morphone is a one-way ticket. Okay? So those are the only two rules you really got to know. Okay, and morphine metabolism, it produces two metabolites. It produces the 6-glucuronide and the 3-glucuronide. 6 is greater than 3, right? It's a bigger number, meaning it's the more effective, desirable one. Okay? It's the active analgesic. The 3, the lower number, the less desirable, is, if anything, anti-nociceptive. It has a long half-life. When there's a collection of it, it can produce myoclonus, it can produce hyperalgesia. And it is possible with IV dosing, we think particularly at higher doses, to get the 3-glucuronide metabolite dominating over the 6. Whereas in oral dosing, 6 pretty much always dominates. Question for you. When concerned about the potential accumulation of toxic metabolites, which are the best choices? So again, in each of these letters, all choices have to be good. A, morphine, hydromorphone, or hydrocodone. B, fentanyl, oxymorphone, or methadone. C, meperidine, methadone, or fentanyl. D, codeine, hydromorphone, and fentanyl. E, oxymorphone, hydromorphone, and fentanyl. So you're looking for the one that has the least potential for accumulation of toxic metabolites. Oops. So fentanyl is not a surprise. I think everybody knows there's not really any toxic metabolites. It does metabolize to norfentanyl, which is not really toxic. Methadone sometimes surprises people, but methadone does not really have active metabolites. It hangs around a long time, but it doesn't have toxic metabolites. Same with oxymorphone, fairly long-acting, no toxic metabolites. So fentanyl, oxymorphone, and methadone do not produce clinically significant metabolites. Okay, another question in this area. Now, instead of looking at toxic metabolites, I'm going to ask you about the risk of drug-drug interactions. So if you're concerned about drug-drug interactions on a particular patient, which opioids are your best to choose? Choice A, morphine, hydromorphone, and hydrocodone. B, morphine, oxymorphone, and hydromorphone. C, meperidine, methadone, and fentanyl. D, codeine, hydromorphone, and fentanyl. E, oxymorphone, hydromorphone, and fentanyl. Again, you're trying to pick the choice where the drugs have the least risk of drug-drug interactions. The answer is morphine, oxymorphone, and hydromorphone. So the way to remember that is morphines are relatively easily metabolized by the liver. Glucuronidation is an easy step. So all the morphines, morphine, hydromorphone, oxymorphone, all the morphine drugs are easily metabolized and therefore are not very subject to drug-drug interactions. Okay, so they're all glucuronidated, very easy for the liver to do, low potential for drug-drug interactions, not really even affected by the genetics of being a rapid or a poor metabolizer. Okay, so back to what we said earlier, just to review, fentanyl, oxymorphone, and methadone, no clinically significant metabolites. The morphine drugs, the morphone drugs all undergo glucuronidation, easy for the liver. Hepatic and renal impairment have less effect on the pharmacokinetics of fentanyl and methadone. So using an example of tramadol, tramadol is based on the metabolism is the 2D6 and the 3, what did we say? I'm blanking on it right now. 3A4, right? So those two are basically the metabolism for tramadol. And if somebody genetically is a poor metabolizer based on their genetic forms of 2D6 and 3A4, then their chance of being a responder to tramadol is about 53%. Whereas if they're an extensive metabolizer, their response rate goes up to 78%. Okay? And the flip side is true, non-responders. So these two drugs, tramadol and tapentadol, are sometimes referred to as atypical opioids. So they do have weak mu receptor agonist properties. And that seems to be part of their effect, but they have other properties that seem to be part of their effect. So for tramadol, it inhibits the reuptake of serotonin and norepi. Serotonin and norepi are inhibitory of pain in the spinal cord. There is no effect on prostaglandin synthesis, so they don't fall at all into the NSAID type of drugs. Tramadol does lower seizure threshold, so you really want to avoid combining it with other drugs that lower seizure threshold, such as many of the antidepressants. Because it inhibits reuptake of serotonin, you want to be careful about giving it with other serotonergic drugs, because now you start to run a risk of serotonin syndrome. It is Schedule 4. Tapentadol, newer, binds also to the opioid receptors like tramadol. Primarily, its uptake inhibition is only for norepi, not for serotonin. Very, very, very little serotonin impact. It does have a risk of seizures. Because of the low serotonin impact, this is, if you're going to use one of these, you would use this one for a patient who is on other serotonergic drugs like SSRIs or SNRIs. It is Schedule 2. Okay, question for you. Compared to short-acting, long-acting opioids demonstrate which of the following properties? Better pain relief, less use of rescue drugs, improved sleep or improved physical function, improved quality of life, no difference in abuse potential. Answer is no difference in abuse potential. We're going to discuss this. So long-acting opioids do not demonstrate better relief, less rescue drugs, improved sleep, improved physical function, improved quality of life, or less abuse potential. Does not demonstrate any of those. So underline old here. The old principles for opioid use for chronic pain was that for chronic pain we needed to use a long-acting opioid for maintenance, use short-acting drugs for breakthrough. The goal was to minimize the use of the breakthrough drugs with the idea that we don't want to chase the pain. Okay. I think when I spoke here 5 years ago, this is how we said it. This is all considered out of date. So long-acting opioids, there's many, many choices. I won't go over them all here, but there's extended release forms of lots of different opioids. And there's a fair number of choices of short-term, or what's considered breakthrough pain opioids. Lots of different choices there, too. So the idea was that long-acting opioids had all kinds of advantages. And we can argue where these thoughts come from. You know, a lot of people have said that the drug companies are responsible for these ideas. I'll stay out of that argument. But what the claims were was that it gave you more predictable serum levels, leading to more predictable pain relief, avoiding many withdrawals. Easy to use once or twice a day. That's probably hard to argue. Greater patient satisfaction. That probably could be argued. Less reinforcement of drug-taking behaviors. So there was more focus on life activities, more of a sense of normalcy in their routines, not constantly reminded of their disease by having to take drugs frequently. They had less risk of acetaminophen toxicity because the long-actings, none of them are combined with acetaminophen. They claimed improved sleep and the possibility of less drug abuse. So let's look at some of the studies. 168 publications were reviewed. 6 randomized trials fulfilled criteria for being basically good studies. None of them found better pain relief. None found less use of rescue drugs. None found improved quality of sleep or improved physical function. None of them even looked at quality of life, so we can't say anything about that. Generally, they did not properly account for or investigate adverse drug events or look at addiction, tolerance, or hyperalgesia. So all of these things different people have claimed, but we really don't have any data. Looking at healthy volunteers, there were 3 trials of healthy volunteers who did use recreational drugs. And it was found that the abuse potential of long-term and short-acting opioids was not different. There is fair evidence from short-term trials that long-acting opioids provide equal pain relief to short-acting opioids. Not better, but equal. So equal efficacy. And a general principle is that lower dosing leads to greater safety. There's a concern that with long-acting opioids there may be a tendency to higher dosing. Okay, let's look at some of the specific drugs. So morphine is the gold standard for opioids. It's cheap. It's indicated for moderate to severe pain. You can use it orally, IV, intramuscular, rectal, and a lot of other ways. It's primarily metabolized by 2D6, excreted by the kidney. Typical half-life is 2 to 4 hours. Onset is, depending on how you view these speeds, considered on the slower side, 10 to 15 minutes after an IV bolus. And we talked about how the 6-glucuronide is the main analgesic. Side effects can give you sedation, nausea, vomiting, respiratory depression. It's rare to find true morphine allergy. Hepatic dysfunction can cause accumulation. Renal dysfunction can cause metabolite accumulation. So if a patient has a renal clearance of 10 to 50, you would want to give 25% less. If their creatinine clearance is less than 10, then you would give a reduction of 50% or avoid it altogether. Asthma, morphine can exacerbate histamine release. The clown is disappointed to hear that It may surprise you that actually morphine, rather than laughter, is the best medicine. Hydromorphone is indicated for moderate to severe pain. It's semi-synthetic. It's 5 times more potent, roughly, than morphine. Again, available in lots of different forms. The enzymes are 3A4 and 2C9, kidney excreted. This should be 2 to 3 hours, and the onset is, again, 10 to 15 minutes. It is metabolized to a hydromorphone 3 glucuronide, which can cause euphoria in higher doses. You don't want to give it to patients with hepatic impairment because they can have an accumulation of dose, similarly with renal impairment. Meperidine, often used under the name Demerol, it's fairly extensive liver metabolism, but it's also excreted by the kidney. Similar 2 to 4 hour half-life. It has a long-lasting metabolite, normeperidine. That metabolite is associated with anxieties, tremor, myoclonus, and seizures. Increased risk of toxicity when used for more than 48 hours. Pre-existing renal or CNS disease would be a reason not to use it. You want to avoid doses greater than 600 milligrams per 24 hours because greater doses really has a high risk of seizures. Potentially fatal interaction with MAO inhibitors. Fentanyl. Moderate to severe pain. It's synthetic, highly lipophilic, a lot more expensive, roughly 100 times the potency of morphine. Available IV, transdermal, transbuccal, nasal spray. 3A4 metabolized, kidney excreted, half-life of about 4 hours, but that depends a little bit on the setting and the form of administration. Onset is rapid, 1 to 5 minutes. Itching is rare, no active metabolites. It is indicated for patients with renal or hepatic dysfunction. Contraindication is allergy. It's good to have a rough idea of how the lipophilicity changes from opioid to opioid. Okay, so this is referred to as the octanol water coefficient. If we set morphine at 1 to 1, then hydromorphone is 4 times more lipophilic, but still not very. Meperidine and methadone are kind of intermediate. Fentanyl and sufentanil are much more lipophilic, dissolving in octanol rather than water. So these are highly lipophilic drugs. Again, you can find a way to get an opioid in, always. Right? If there's a way in, you can put an opioid there. It can be rectal, transdermal, intravenous, spinal, intraventricular. I mean, you name it, you can put it there. Okay, your doc says if you like, you can swap your branded pills for these generic suppositories. There's always a way in. So PCA, patient-controlled analgesia, is a fairly nice way in an acute setting to use opioids. But you want to reduce the dose of how you set your PCA if they have coexisting diseases of these types. Pulmonary disease, congestive heart failure, sleep apnea, head injuries, hepatic or renal failure, altered mental status, or lactating mothers. Here's an equal analgesic chart. It helps you figure out oral and IV doses and also helps you compare one opioid to another. As a rule of thumb, when we convert opioids, we always underdose with a plan to come back. 2 main reasons. One is when you're switching, there's this thing called incomplete cross-tolerance. So even though these numbers say that 30 of morphine is equal to 7.5 of hydromorphone, they may not be as equally tolerant to the hydromorphone as they were to the morphine, so it may be stronger. So you always lower the dose. And then the other thing is these numbers are based on the bell-shaped curve, population bell-shaped curves. And your patient may not be in the middle of the bell-shaped curve. So always underdose and just have a system to bring you back up after you see how they react. Typically, we underdose by about 1/3 of the calculated dose equivalents. Okay, so let's run through this. You have a patient getting IV morphine, and it turns out that they're using 48 milligrams in 24 hours. So you want to figure out the oral equivalent. You multiply by 3. So they're using 144 milligrams in 24 hours. But now we're going to underdose, roughly by 1/3. Pick a round number, so if we reduce by 38%, that gets us to 90 milligrams of oral morphine a day. If we're going to use a drug that has an 8-hour half-life, such as, or an 8-hour dosing schedule, such as MS-Contin, then we would divide by 3, and that would give us 30 milligrams every 8 hours. If, on the other hand, you're going to switch to a different drug like oxycodone, well, oxycodone is roughly 1.5 times the potency of morphine. So you would have to reduce that 90 milligrams a day to 60 milligrams a day of oxycodone. And you can get to that by using a short-acting drug like Percocet, or OxyContin, 30 milligrams every 12 hours, or 20 milligrams every 8 hours, all would give you that 60 milligrams per day. And this has a built-in dose reduction, again, of 38%. Okay, we are ready to go to our fourth section.